The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/MMX860. Downloadable slides and practice aids are also available.
Hello, and welcome to our virtual webcast, Evidence and Insights on Innovative Treatment for Bladder Cancer. During this event, we'll use a tumor board format with my colleagues Dr. Grievous and Dr. O'Donnell to explore the implications of a wave of new evidence on immunotherapy, targeted agents, antibody-drug conjugates, and many other treatment paradigms that are quickly changing in the treatment of bladder cancer. So tonight, I'm joined by my colleagues Dr. Petros Grievous and Dr. Peter O'Donnell, who will be joining me today in this very thoughtful discussion. So today's agenda, let's talk through it. We're going to discuss some case studies in advanced bladder cancer covering both first and second line treatment options. We'll also focus on a patient who is diagnosed with newly diagnosed muscle invasive bladder cancer and discuss the treatment options available for these patients. And then also lastly finish with a patient who has BCG unresponsive non-muscle invasive bladder cancer and highlight some of the new and emerging therapies that are being tested in this particular population. So as I mentioned before, we'll be using a tumor board format to highlight some of these new advances. And I'd like to first begin with this particular case, a gentleman named William. He's a 79-year-old man, and he has stage 3B chronic kidney disease, so renal impairment, and also type 2 diabetes mellitus, and is a current active tobacco smoker. And this is the classic patient who's diagnosed with bladder cancer, unfortunately. He presented initially in November 2018 with hematuria and was found to have a bladder mass. He gets a urine cytology examination by his urologist, which demonstrates high-grade urothelial cancer. He undergoes a transurethral resection of a bladder tumor, and this shows a high-grade urothelial carcinoma that is invasive into the muscularis propria, and a CAT scan urogram, which is a typical CAT scan that we do in this patient population, demonstrates diffuse mass-like thickening of the anterior wall with extravesical tumor extension. So this is a clinical stage T3 tumor. Additionally, what we find out on this CAT scan is that he has retroperitoneal lymphadenopathy, this large conglomerate of nodal mass near the pancreas, and also the renal hilum. And so the basic question we have is, so we have an elderly gentleman, he has chronic kidney impairment, some type 2 diabetes. He's now diagnosed with a muscle invasive urothelial cancer, also with retroperitoneal lymph nodes. So this is a patient with M1A disease. So it's important to recognize this is some patients will have pelvic lymph nodes, but this patient has disease outside of the pelvis, so he actually does have M1 disease. So one of the biggest questions we ask is, how do we approach treatment for these patients? I'd like to start off this conversation with you, Dr. O'Donnell, which is, can you tell us a little bit about cisplatin eligibility, ineligibility, and also some of the new treatment options that have been developed for patients who are ineligible for cisplatin-containing chemotherapy?
Yes, this is a great case because, the problem of cisplatin versus other therapies is a common one that we encounter. Cisplatin-based therapy is the gold standard for metastatic urothelial cancer like this patient has, and it has been for many decades, but we all know many patients cannot receive cisplatin. This patient has probably the most common reason for not being cisplatin eligible. That's his poor renal function. So cisplatin's not an appropriate choice here for this patient. Other common reasons that we see in this population for being cisplatin ineligible might be, class 3 heart failure, poor performance status, peripheral neuropathy that can preclude use of cisplatin, or even hearing loss that's significant. So this patient, I would not be able to administer cisplatin. And then really the question comes down to, as you're asking here on the slide, do we revert to carboplatin-based therapies where we know that carboplatin is an inferior drug for this disease? Perhaps in other tumors, there is some interchangeability between cisplatin and carboplatin, whereas in urothelial cancer, carboplatin definitely seems to have inferior outcomes and has really never been shown to extend survival for this disease. So it is a tough choice in that, we know already from right out of the gate that this patient is not going to be getting an optimal type of therapy. If we go with carboplatin-based therapy, a classic would be gem-carbo here in this case. And I think there'd be a lot of interest to consider upfront immunotherapy if this patient was eligible. And really the eligibility comes down to whether he has expression of PD-L1.
Yeah. So can you walk us through some of the data for the use of immunotherapy? I think two very important, albeit single arm trials, which have obviously the limitations, IMvigor 210 cohort 1, as well as the Keynote 52 study. Can you tell us a little bit about those?
Sure. These were both single-arm studies that looked at the use of immunomonotherapy in this frontline setting for the disease in patients who were cisplatin ineligible. You can see that in the atezolizumab study, the response rates were in the 20-some%, which is actually very typical for what we would see with immunotherapy, even in the second-line space as far as a response rate. You can see that there were a handful of patients that had complete responses, which is really one of the characteristics that we look at in this setting, because those patients that achieve a complete response may have durable control of their disease. And just to reflect back on something we were just talking about with carboplatin-based therapy, we almost never see complete responses to carboplatin-based therapy. So the fact that we're seeing that with these immunotherapies in this frontline setting is really a marker that catches our interest. You can see that the pembrolizumab study had very similar types of response rates in the 20s, the high 20s for that drug, with a similar complete response rate of almost 10% of patients. And there were even data that are not shown on this slide, or actually they're on the third bullet point, that in those patients that express PD-L1, that the response rates approach 50% with very long overall survival numbers. And so this is really what led to the use of these two drugs. They received approval in this frontline space, and the use is now restricted to those patients that express PD-L1. So a cisplatin ineligible patient that expresses PD-L1, these would be a very attractive frontline choice. The other factor that I always think about, in treating these patients is, your frontline patient, if they have a lot of symptoms from their disease, right? If they've got a lot of pain, or if you have a sense that they're rapidly progressing, that's the type of patient that I might still use Gem-Carbo. But, if your patient's like this one, where, he was seen on a scan, he's got lymph node only disease as far as we can see, those patients are ones that I really like to think about using immunotherapy in that frontline space. So I'll send their tumor for PD-L1 testing. And as you can see here on this slide, the FDA labels were changed to restrict that use to patients expressing PD-L1. And I think it would be a great choice for this patient if he expressed PD-L1.
Great. So let's continue with the case. So in December 2018, he's considered ineligible for cisplatin due to his kidney function, just like you said, Dr. O'Donnell. And he has tumor testing that shows a CPS score of 10% or greater. So he meets the label indication for the use of pembrolizumab. And he starts treatment, and he achieves a partial response after 2 cycles of treatment. And after 11 cycles of therapy, he develops a complete response, which is, certainly what we observed. And, being all 3 of us having participated extensively on Keynote 52, we saw many stories like this. And I think it's important to highlight that patients can achieve these types of responses and outcomes, durable remissions, and have successfully avoided chemotherapy. But there's the 2 sides to this, obviously. What are the safety risks? So what if he develops an immune-related adverse event during this treatment? So Dr. Grivas, can you walk us through a little bit about how we think about when do these adverse events occur? What are the nature, the frequency, the severity, and how do we generally manage them? Can you walk us through a little bit of this?
Absolutely, Arjun, and thank you for this question, because it's an important need for all of us to stay educated about the immunotherapy-related adverse events, so-called IRAEs. And this can be in variable frequency, depending on what checkpoint inhibitors we may use, single agent versus combination. But at least in urothelial cancer, that we have the paradigm of single agent checkpoint inhibitors, I would say that the immunotherapy-related adverse events can occur in a significant proportion of patients, and about 15% can develop what we call severe or grade 3 or higher immune-related adverse events. And this is something we have to be vigilant for. We have to educate our patients to call us anytime with any change, because the immunotherapy-related toxicity can affect any organ. So the gut, the lungs, the liver, thyroid, skin, many other organs can be potentially affected. So I think it's an important educational piece for us, the advanced practice providers, the patients, and their caregivers to report any change that can happen. The timeline of this occurrence can vary depending on the side effects, but can occur pretty much anytime from the onset of immunotherapy until later on. And rarely after the completion of immunotherapy, something to keep in mind that can happen, later on. And there are several recommending strategies for the early recognition and optimal management for IRAEs. And of course, there are guidelines from NCCN, from CITSI, from ASCO, from ESMO. And all these guidelines provide good evidence-based and also consensus-based recommendation, and mainly consensus-based because it's hard to generate evidence in this condition of how we manage those adverse events. Usually for grade 1, we're able, in most cases, to continue immunotherapy and do symptomatic therapy, best supportive care. For grade 2, usually we tend to withhold immunotherapy and consider steroids to suppress the immune system, and the dose is usually 0.5 to 1 milligrams per kilogram per day, or an equivalent dose, and then we can taper the steroids, usually slowly, because a rapid steroid taper can lead to a rebound immunotherapy-related toxicity. Grade 3 or 4 is more severe, often requires hospitalization, IV steroids, and sometimes requires permanent discontinuation of the offending immunotherapy agent, depending on the case, depending on the type of IRE, depending on the severity. And I think it's important to keep in mind that there is a broad differential diagnosis. Not every symptom is toxicity because of immunotherapy, and detailed workup is needed. Consult of the expert, for example, diarrhea, discussion with gastroenterology, so on and so forth, and consideration of additional immunosuppressive therapy early on if the steroids do not work to control the disease. So it's a multi-specialty context, and in that note, many centers like ours in University of Washington and Seattle Cancer Care Alliance and FERHADS, we have a multi-specialty tumor board and immunotherapy-related tumor board, how to address those acute issues sometimes, or discuss about the optimal management of this adverse event. So very important point, and Arjun, thank you for bringing this up.
Yep. So I think, there are a couple of key points about immune-related adverse events that I've learned over the years is that even after patients have stopped treatment, even several months after they've completed the therapy, they can develop immune-related adverse events. I've had 2 cases, one patient who developed basically an immune-related encephalopathy 4 months after their last dose. And also important to recognize that endocrinopathies can also be delayed. I've had a few patients who had no thyroid abnormalities throughout treatment, and then 4 or 5 months later, they're presenting with fatigue and some nonspecific symptoms, which I thought were disease-related, and we check a thyroid panel, and all of a sudden, they've got hypothyroidism. And that's what ultimately was the cause of the symptoms. And so I think it's important that, again, as you pointed out, is that it's before, during, and after, actually during and after, that you really have to be careful about all this. And most importantly is that we intervene at grade 1 and grade 2 so we can prevent grade 3 and 4 from ever happening, because we know that the high grade events are usually what leads to the most significant complications. So let's move on to the next case. So we've got Mr. Bertrand. He in January of 2017, he's diagnosed with muscle invasive bladder cancer, and ultimately he chooses to undergo a cystectomy. And the cystectomy pathology at that time shows PT3N1 high-grade urothelial carcinoma. And on the basis of that pathology, he's able to receive adjuvant cisplatin and gemcitabine chemotherapy. Subsequently, in December of 2018, so now you're looking at almost 2 years later, he's got a CT scan that's now showing relapse disease with a rib metastasis that you can clearly see on the CAT scan there. Workup at that time, he's got an estimated GFR of greater than 60 cc's per minute. His ECOG performance status is 0. He's got basically some minimal tenderness in that site, and otherwise he's really not impaired in any sort of way from his disease. And so now the question I would ask is that in this context, well, he's relapsed, but it's close to 2 years later. Should he be retreated again with platinum-based chemotherapy? Because is he kind of like a first-line patient because it's been so long? What about immunotherapy, about combination approaches? And I think one of the most critical questions here is, where you're considering platinum-based chemotherapy or immunotherapy and kind of choosing between the two, what about doing both together? And I think that's a really important question that we've been waiting to ask and answer in metastatic urothelial cancer. So Dr. Grivas, can you walk us through some of the data for combination approaches, including chemotherapy plus IO?
Absolutely, and that's a very important clinical dilemma, especially when you see patients who relapse, as you mentioned, Arjun, after 1 year from the completion of neoadjuvant or adjuvant systemic chemotherapy, cisplatin-based. And so far, if we think about the data in totality, we have some results, findings from 2 frontline concurrent chemoimmunotherapy trials. The first one was reported by Dr. Grant and colleagues at ESMO 2019 meeting almost a year ago. And this was the IMvigor130, which actually had 3 arms. Arm A was chemotherapy, cisplatin or carboplatin plus gemcitabine plus atezolizumab was Arm A. Arm B was atezolizumab alone, and Arm C was the platinum, cis or carbo plus gemcitabine plus placebo. And as you see in that slide, the Arm A prolonged progression-free survival compared to Arm C. The difference in the median PFS was about a couple of months. You can argue this time of that one scan takes place after another, and there was no significant, statistically speaking, difference in overall survival. So based on this data, and also in the context of the recently reported press release from the Keynote 361 trial that I will talk in a second, currently there is no role, in my opinion, of concurrent administration of chemotherapy plus immunotherapy. We can talk later about the sequential approach of a maintenance therapy, but I think right now you have to choose your modality and do either chemotherapy or checkpoint inhibitor, but not combine them. And since I mentioned the Keynote 361, there was a press release a few weeks ago. There was a very similar design with IMvigor130 trial, but the difference was pembrolizumab and not atezolizumab. And that press release reported that the chemotherapy plus pembrolizumab compared to chemotherapy alone without immunotherapy did not statistically prolong PFS or OS. And that was a surprise to many of us. But so far, based on these 2 trials, there is no role of combining the 2 modalities as we do in other malignancies. What do you think, Peter, about that, Dr. O'Donnell?
I agree with your take on the data. I mean, the IMvigor130 overall survival data are immature at this point. And so we need to continue to track that. The use of immunotherapy, I think that we're going to touch on this later. Perhaps the idea is not so much that it needs to be combined with the platinum-based therapy right up front, but it probably is moving earlier in the spectrum, as we'll talk about the idea of maintenance immunotherapy in a bit. And it's possible that this idea of starting the immunotherapy sooner, whether it's with platinum-based therapy up front or right after platinum-based therapy ends, maybe that's what's making some of this difference that we're seeing on the progression-free survival or even the overall survival. So I think we'll come back to that question later. But right now, you're absolutely correct. The IMvigor130 data as they stand right now, we're unfortunately not practice changing.
And
that brings us to another question, which is that, well, if it's chemo plus immunotherapy is not the answer, are there any other combination approaches that may challenge this notion? Is it immunotherapy plus something else? Dr. O'Donnell, I think I think everybody in the bladder cancer universe knows about the EV-103 trial and some of the very promising data that we saw in that study. Can you walk us through some of the data that was presented at ESMO last year, and what's in the future for this combination? How are we going to test it moving forward?
Sure. So here we're talking about the idea of completely perhaps changing the landscape of the frontline setting, right? If our gold standard always was platinum-based therapy, now we're looking at this drug, enfortumab vedotin, or EV, which of course has approval in the essentially third-line space, and it's being looked at in this frontline trial that you're showing here on the slide in combination with pembrolizumab. And so the results that were presented really show an impressive response rate and some durability to that data as well. The data that have been presented here on this slide show an overall response rate of over 70% with this combination. Now, to put that into context, right, cisplatin-based therapy, Gem-Cis, has a response rate of under 50%, right, just under 50%. So this type of response rate really is impressive in this frontline population. You can see that, almost over 90% of patients had some degree of tumor reduction with this. And the survival data that were presented at GU ASCO this year by Dr. Rosenberg really shows some durability of this combination as well. So there's an ongoing study now looking at this combination compared to platinum-based chemotherapy. And I think that will be really interesting as we think about this very, rapidly changing frontline landscape.
Yeah, I think some of the most exciting data as part of this study is not only just the eye-popping 73% response rate, and we don't see that kind of data in any study in advanced bladder cancer, but also that about 93% of patients had at least some degree of tumor shrinkage. which at that point pretty much tells you there's really no biomarker to tell you that there's 93% activity, right? You don't need a biomarker for 93% activity. But then the ultimate question is like, what is durability? Because I think when anyone talks about immune synergy as the sum greater than the component of equal parts, then really durability answers that question. And at this follow-up that Dr. Rosenberg presented, the median DOR has not yet been reached for all the patients who achieved a response. And so I'm really quite excited about this. All that being said, it's 47 patients, phase 1 study. We need to test this. EV302 is the very large phase 3 trial that is comparing platinum chemotherapy alone versus enfortumab plus pembrolizumab versus enfortumab plus pembrolizumab plus platinum chemotherapy. A big effort, and hopefully that'll answer these questions more definitively. And also there's cohort K of the EV103 study, which is taking this exact regimen and randomizing cisplatin ineligible patients to either enfortumab alone versus enfortumab plus pembrolizumab. That actually has registrational potential. It's 150 patients. And that study is actively accruing patients, and hopefully we'll see some exciting data. And so, this is something that, in my opinion, that could completely change, the bladder cancer world completely. So let's move on with the case. So let's assume Bertrand, he goes on to receive cisplatin-based chemotherapy. He's rechallenged with it 2 years later. And a decision is made based on his own personal preference. And, he actually tolerated chemotherapy well before. And he said, well, you know what, let me give it another shot. And lo and behold, he gets a CR after 6 cycles of chemotherapy. Probably something I wouldn't have expected to happen, but let's say it did happen, right? So now the question is that should we be using maintenance immunotherapy, right? So where does immunotherapy fit in all this? And of course, Dr. Grivas, you're no one better here than to discuss the data from that particular study, the Javelin Bladder 100 trial. Can you walk us through the design of the study and the argument to potentially use maintenance immunotherapy in this patient who's achieved a really good response after platinum-based chemotherapy?
Sure, Arjun. I agree with you. It's a good thing that this patient got. It's a great thing. This patient achieved a complete response. As you said, it's not a very common scenario, especially in patients who are pre-exposed to cisplatin. But as we discussed before, there was a long, relatively speaking, progression-free interval between the last dose of adjuvant GemCis and his recurrence. Now we have a situation where this patient has complete response, cannot give chemotherapy forever because of toxicity, as we all know, bone marrow suppression, neuropathy, hearing changes, and other side effects. So the notion has been, can we maintain or sustain the benefit from immunotherapy, benefit meaning a response, CR, PR, or stable disease achieved with chemotherapy that altogether are seen in about 80-85% of patients, if you exclude those with progression who move on with second-line therapy. Can you maintain this benefit with chemotherapy with a switch maintenance approach, switch to a different modality? And to answer this question, the Javelin Bladder 100 trial was designed about 6 years ago, and the patients were randomized after the completion of 4, 5, or 6 cycles of gemcitabine plus cisplatin or gemcitabine plus carboplatin to either avelumab, an anti-PD-L1 immune checkpoint inhibitor, or plus best supportive care, or best supportive care alone, observation, pretty much surveillance, with frequent CAT scans and surveillance methods. And the patients were stratified based on the metastatic site, visceral versus non-visceral metastasis, as well as the best response to chemotherapy, CR, PR, or stable disease. And the primary endpoint was overall survival in all comers, as well as in the subset of patients with PD-L1 positive tumors. And in that particular slide, we see the main results of the Javelin Bladder 100 trial that Dr. Powles presented at the ASCO plenary session just a few weeks ago, the ASCO virtual meeting. The primary endpoint of overall survival was met. This is the Kaplan-Meier curve for all comers. You see that the hazard ratio stratified was 0.69, representing a 31% reduction in the risk of death. The median overall survival, there was a difference of 7.1 months, favoring the avelumab arm. And if you look at the landmark overall survival at 18 months, 61% versus 44% were alive in the avelumab arm versus the best supportive care arm alone. In the two, there's a significant difference in the two curves, which start to separate, I would say, early on at the time of the first or second scan, and the curves stay separated all along. And if you look at the subset of patients with PD-L1 tumors, that was the other co-primary endpoint, similar results, hazard ratio 0.56, the median overall survival non-reached with the avelumab arm, and 17.1 months with the best supportive care arm. with significant p-value in both of those analyses, and a pretty significant widening of the curves, I would say, early on and all along throughout the follow-up, which was about 19 months or so in the study. I think it's important to point out that the PFS was also met in both populations, all comers and the PD-L1 positive population. And there was also a difference in response rates. And we all know response rates are difficult to discern in this and really analyzed in this maintenance strategy. About 62% of patients had subsequent therapy in the best supportive care alone arm, and only 44% of patients of the best supportive care alone arm received checkpoint inhibitor at progression. And we had discussions before that this is actually lower than what we hope for. However, it probably represents the real world setting based on retrospective and also prospective data, because there is significant drop off of patients who do not make it to second line based on different retrospective data sets and another trial recently by Dr. Galsky in the maintenance setting. So overall, I think, Arjun, this represents a new standard of care. This is going to change practice in the way we treat those patients in the frontline setting with switch maintenance approach in those with response or stable disease. But I would love to hear both your thoughts on this. Peter, you may comment, and then Arjun, I want to hear both of you.
Yeah, so so one of the questions I have is for patients like a trial design like this. I think you mentioned, well, 85% of patients will be in this category. Do we really think that in a pooled group of cis and carbo treated patients, that 85% achieve not only at least stable disease, but stable disease lasting long enough to have been eligible for this trial, which includes a repeat CAT scan up to 10 weeks after they completed chemotherapy? I'm not so sure that necessarily is the case. I think that number is actually probably smaller than 85%. And then the question is that, does this necessarily mean that all patients should receive platinum-based chemotherapy as the first-line treatment? I would argue that this is not a first-line trial. This is a maintenance trial. All patients receive chemotherapy. And then the question is that if they've had a good outcome to chemotherapy, what do you do next? So my feeling is that this is not really a first-line trial. And the conversations we have about first-line treatment, chemo versus IO, those are still intact. And we still haven't answered those questions just yet. So that's my feeling about it. Dr. O'Donnell, what do you think?
Yeah, the great points you're both making. A couple considerations here for me. In our cisplatin treated population, we talked earlier about the fact that some of those patients are going to have durable CRs.
Absolutely.
Putting those patients on a maintenance strategy like this is probably over treatment. And so I don't think that, every patient should be considered for this, right? You might consider it more in that gem carbo frontline treated patients who's unlikely to have durable benefit from that platinum-based therapy. And you do feel pretty uncomfortable just surveying that patient after carboplatin-based therapy. So a maintenance strategy here in that population might make a lot of sense. The other consideration here, is just a practical one, right? In this trial, avelumab was given indefinitely, and it's an every 2-week drug. So, how long are patients going to be really willing to come in every 2 weeks for a maintenance treatment that they may or may not need? So I think it's a practical question that we're going to sort through with our patients.
Absolutely. So speaking of which, there's some really great questions that we're getting in from the audience just right now. And you spoke about every 2 weeks dosing. One of the questions we just got from the audience right now is, well, what about extended dosing with pembrolizumab? And it's every 6 weeks dosing now. Dr. Galsky did a study very similar in design, much smaller, wasn't powered for an OS detection, and benefit. But you could ask the question, well, in a maintenance setting or even in the second line setting, does pembrolizumab become a bit more attractive, especially in the context of COVID-19? What do you think?
Yeah, I do think that this is probably going to happen in actual practice. Pembrolizumab, has a lot of comfort level with practicing oncologists as it is in the bladder space. It's got this very attractive every 6-week dosing schedule. So it probably will happen. There's data that would speak to supporting that, but not the strength of the data that we're looking at with avelumab. So we have to be careful about that. Regarding this idea of the extended interval for our patients in general, related to the pandemic, the timeliness of pembrolizumab's approval with this schedule, I think, was perfect in the sense that a lot of us were looking for ways to try to maintain our patients during the height of the pandemic And it really, came in handy and was an attractive way to try to make sure that these patients could continue to be treated. But we have to remember at the same time that it's probably not appropriate to do every 6-week dosing for every patient. I probably wouldn't feel comfortable with this as I'm just starting a patient on immunotherapy. You really want to monitor that patient, as we just
Yeah.
talked about. With immune-related adverse events, those are most likely to happen in the first couple of months of treatment. So, the 6-week dosing is probably best for those patients that are already doing quite well on immunotherapy. You feel very good about the stability of their disease, and now you just want to make this a little more easy for them to receive.
Yeah, that's exactly what I've kind of done, is that patients, I use the phrase, kind of when they're cruising on immunotherapy, they're doing quite well. They're very happy to hear about every 6 weeks. I did it almost immediately, and I can't tell you how many happy faces were like, oh my gosh, I don't have to come in, but every 6 weeks, they were just thrilled to have that option. But I agree with you, when patients are first starting out, you need to see how they are, and you need to lay eyes on them. And if that means coming in every 3 weeks just to make sure they're doing okay, I think there's a lot of value in maintaining that at least early in the course of treatment. All right, so let's move on to the next case. So we've got Mark, who is a 75-year-old gentleman with metastatic bladder cancer. He's got disease in the pelvis, retroperitoneal lymph nodes. He's got lung disease, and he receives gemcitabine and cisplatin chemotherapy. And after 6 cycles and an initial stable disease, and he subsequently has tumor progression on his most recent CAT scan about 3 months after that. He's still got an excellent performance status, ECOG PS of 1. He has a little bit of peripheral neuropathy, as expected from the cisplatin-based chemotherapy. His labs are otherwise normal. Hemoglobin is 11.2. No autoimmune history, so nothing to preclude a safe administration of immunotherapy. He gets next-generation sequencing on his tumor. Unfortunately, he doesn't have an actionable FGFR alteration. And for patients like this, I think we commonly treat them with immunotherapy. I think we have data now in the second-line setting for patients who progressed, including a phase 3 trial, Keno-45, that demonstrates a survival benefit against single-agent chemotherapy, either with a taxane or vinflunine, demonstrating superiority in terms of response rates, as well as a hazard ratio favoring survival of 0.70 at its most recent update. And so clearly immunotherapy improves survival in the second line setting. And obviously we have a smattering of data from other phase 1 and phase 2 studies for both PD-1 inhibitors as well as PD-L1 antibodies. And in general, we basically have accepted that immunotherapy is the standard of care in the second line setting after platinum-based chemotherapy. But let's move forward. Mark, he gets an anti-PD-1 antibody, or anti-PD-1 or PD-L1. We won't be necessarily specific there. He achieves a partial response after 3 cycles of treatment. And after 18 months, initially has a good PR, it lasts for a good 18 months. Now he has symptomatic progression, and also it's confirmed on imaging. So during treatment, he had experienced a grade 2 immune-related adverse event with colitis, treated very successfully with corticosteroids, and immunotherapy was safely resumed. So that's pretty much all he had during immunotherapy. So next question. So we have a third-line patient who's progressed platinum-based chemotherapy, immunotherapy, third line. So what are the treatment options that are out there, approved agents as well as emerging agents? Dr. Grivas, can you walk us through some of the data for some of the emerging therapies in this space?
Arjun, that's an important question. This patient has already received frontline standard therapies, received chemotherapy, now immunotherapy, and has a pretty good, I would say, course so far with 18 months on immunotherapy, and now has progression. The challenge, of course, is the toxicity, as you pointed out, and toxicity can happen, as you mentioned, treated successfully with steroids, but now has progressive disease. And the option at this point of time, the FDA-approved options have to do with the antibody-drug conjugate and enfortumab vedotin, and we're going to look at the data. And another option is erdafitinib, which is FGF receptor inhibitor, and we can look at the data of erdafitinib later. But if the patient has no FGF receptor 2 or FGF receptor 3 activating mutation or fusion, then if this is not present, the patient would not qualify to have erdafitinib. So the only FDA-approved option in this third-line setting is what Dr. O'Donnell mentioned before, enfortumab vedotin. And the data so far has been really impressive. And enfortumab vedotin is an antibody-drug conjugate, anti-nectin-4, and has a linker that links Nectin-4 antibody with MMAE, monomethyl auristatin E, which is a toxin that also is used in the brentuximab vedotin, and providers who treat lymphoma may be familiar with that toxin. And this agent has accelerated approval for patients with metastatic urothelial cancer previously treated with chemotherapy and immune checkpoint inhibitor. It's a very important, I think, improvement in this disease space and a great option for this patient. The other antibody drug conjugate that has captured some attention is the Substitution of Govitikan. The data so far has been less compared to the enfortumab vedotin. It's a different target, and the TROP2 antibody linked with a different toxin, the SN38, which is a metabolite of irinotecan. And there is encouraging, promising data with overall response rate of 29% in patients with multiple prior therapies. And I think this agent is now finishing a phase 2 trial testing, and we're waiting for the final results of the phase 2. Preliminary results of the phase 2 were presented. If we focus the attention back to enfortumab, we have the V201 study that reported and was now published. And I think many of us had patients in this study. The overall response rate was 44%, which is pretty impressive in the third line space in previously treated patients. As we think about the historical benchmark of docetaxel chemotherapy, response rate can be about 15%. So this definitely seems to be almost triple of what we expect with taxane single agent. And 12% has complete response rate. So very, I would say, important and impressive data. I think it's important to point that more than 80% of patients in that particular study, the phase 2 study, had a reduction in the tumor size. So the clinical benefit appears to be beyond the classical RECIST 1.1 restricted response rates. And the toxicity profile is something we have to think about, and we'll talk a little bit more in the next few slides. But I think if we can highlight some of the key toxicities with enfortumab vedotin, peripheral neuropathy is important, and it's something we have to keep in mind even more in patients who had platinum chemotherapy before. Peripheral neuropathy can be about 50% in patients treated in this study, but most patients, 3 out of 4, had a resolution or improvement of grade severe grade neuropathy to grade 1 or less. Skin rash is another relevant side effect, and this can be variable in the time of onset of presentation or response to management, but something we need to take into account and have to treat it usually with topical agents, topical steroids, and the histamines, and sometimes may require systemic steroids. And hyperglycemia is something we have to definitely keep in mind. It happens in about 10% of patients, and about half of them can be very severe and can potentially be lethal. There's this constellation of this metabolic syndrome that we see in a few, rarely I would say, in a few patients that can be associated with hyperglycemia, acidosis. It does not require prior presence of diabetes, so have to pay extra attention. It has a correlation with higher BMI, but even patients with lower BMI can develop that. So extra attention, I would argue, with this agent. And I think it's a very, very impressive response rate and extra attention to the side effect profile. What do you guys think about that?
Yeah, I think this is probably one of the most important drugs that we've added in our armamentarium for a while. You know, in patients in the second line setting are receiving immunotherapy, or heck, even in the first line setting, we know that a substantial proportion of patients won't benefit. And my experience has been on this study and use of commercial product is that this many times can rescue patients from their disease, get rapid disease control, in particular in patients with liver metastases, where you're seeing response rates in the 40 to 45% range. We really don't have drugs that work that well in the liver. If you look at single agent immunotherapy, the best response rates we see with pembrolizumab are around 17%, and with atezo, it's down to 8%. So we know that this is a treatment refractory population, and then all of a sudden to have this drug, which is quite active, can often get disease under control within the first cycle of treatment. And what I've noticed quite possibly is that a significant palliation of pain, even in patients who don't necessarily demonstrate a RECIST response, you'll get a palliative effect. But the safety concerns are very real, and I think we need to be careful about how we use these drugs. But I think that plus the data that Dr. O'Donnell discussed about EV in combination with pembrolizumab as first-line treatment tells us that there's much more to come with antibody drug conjugates in general in this disease. So let's go to let's go to another level of this patient's case. So Mark, so let's say we'll change things up a little bit now. So Mark, he instead gets specifically an anti-PD-L1 antibody. It still achieves a partial response after 3 cycles of therapy. After 18 months, not 18 years, but after 18 months, he develops symptomatic progression confirmed on imaging. And at this point, he gets next generation sequencing of his tumor, and he in fact has an S249C FGFR3 mutation, classic activating mutation in FGFR3. So what about the next step here? So things that I'm curious about is, Dr. O'Donnell, what do you think about trying in a PD-1 antibody in this case? So PD-L1 switching to PD-1. Also, enfortumab, we've kind of already talked about that, but what about erdafitinib, which is an FDA-approved agent that targets FGFR signaling? So can you walk us through some of these thoughts?
Sure. So this is where, things have really changed quite a bit in just the last year and a half, right? If this patient was a year and a half ago, really there's not a good option for this patient now who's, unfortunately progressing through immunotherapy. I don't see any rationale for, trying a different immunotherapy in my own personal practice here. I know that there is some, talk of people switching from an anti-PD-L1 to an anti-PD-1. To me, that would not be an appropriate strategy in the world we live in right now, where we've got 2 drugs now that are approved exactly for this situation, post-platinum, post-immunotherapy progression. So enfortumab, we've already talked about. Dr. Grivas did a great job walking through those data. Why don't we look at erdafitinib, which now this patient would qualify for with the FGFR alteration. Erdafitinib is a tyrosine kinase inhibitor that blocks the signaling through the FGFR pathway. FGFR signaling is believed to drive tumor progression, metastases in a portion of patients with urothelial cancer. You can see the overall frequency of alterations in FGFR is probably about 15% for urothelial cancer, advanced urothelial cancer. It's probably a higher number of patients that have upper tract disease as their primary tumor, where FGFR alterations are probably altered in up to a third of those patients. You can see that in non-muscle invasive bladder cancer, FGFR alterations have been known for a long time to be present, but it's a lower frequency when we're talking about metastatic urothelial cancer, as is shown on this slide. So the drug erdafitinib was demonstrated to have efficacy in this trial that was published in the New England Journal of Medicine. The drug was used in a single-arm fashion, all patients receiving this oral therapy who had been through prior platinum-based therapy. Some of the patients had also been through immunotherapy in this trial. The overall response rate was 40% in this trial, with, again, in this refractory treatment population, an overall survival that approached 1 year. So data that were very attractive. The number comes in right around the number we're seeing for enfortumab vedotin. And so, as we have with this patient who carries the activation, which therapy would we choose? That's often a topic of debate. It's a wonderful thing to have, 2 possible drugs for a patient like this. And really it comes down to, what are the goals for this patient? Do they want an infused drug, that they're going to have to come in weekly every 3 weeks, 3 weeks out of every 4? Is that attractive to some people who don't want to have to worry about taking an oral therapy? Or, is it cumbersome and they'd rather get an oral therapy like erdafitinib? So that's one of the conversations that I have with patients. But from a response rate standpoint, the 2 appear very similar in this population, and I think that both would be appropriate. There are some toxicities with erdafitinib, that need to be considered. It is a tyrosine kinase inhibitor. It's got a lot of sort of the chronic TKI-like toxicities that probably a lot of us are familiar with, using TKIs in other diseases. So those are considerations. The one, that's gotten a lot of publicity is the ocular toxicity of this drug. Central serous retinopathy did occur in a significant portion of patients, most of those at lower grades, but there have been instances of patients having actual visual disturbances and visual loss with this drug. There is a requirement that patients undergo ophthalmologic exams and on a regular basis while being treated with erdafitinib. A lot of us, I think, in practice find that to be a pragmatic limitation of using the drug, because it's sometimes tough to get in to the ophthalmologist for our patients in a timely manner. The other thing that I'll mention with this drug is it can be difficult from a standpoint of nurse management. There are a lot of dose adjustments that need to be considered for this drug based on the serum phosphorus level. And so you have to be drawing phosphorus levels on a regular basis when starting this therapy, and then dose changing erdafitinib based on where that phosphorus comes in. And so I've found that cumbersome for the drug to be used in a portion of my patients where all these frequent lab draws, changing the dose, having to reorder new pills because the pill size doesn't work out with the dose that they then to be changed to. So that's a consideration, I think, in practical use of this drug.
Yeah, I mean, I think important thing for oncologists who aren't used to ordering ophthalmologic exams outside of protocols, we are not used to doing that, right? And so for community oncologists to find not only an ophthalmologist for the patient to send to, but also to tell the ophthalmologist what they should be looking for. Like, what is the toxicity? Because they're going to ask us, erdafitinib, what's that? And then, of course, they know what CSR is. And so obviously, there's a little bit of discussion there. But I think, rolling this out in the community in particular, where we're not used to drugs having ocular toxicity, at least in the oncologic world, is something that's really important to highlight. One of the really good things that came from the ASCO presentation that, again, highlighted some of the data with regard to ocular toxicity is that the majority of the events happened early within the first couple of months of treatment. And so I think that's where we have to be very vigilant. And then the greater occurrences of, let's say, a grade 2, 1, 2, or 3 really didn't happen later on in the course of treatment. So it tells us a little bit about when we should expect the toxicity, which is generally pretty early in the course of treatment. So some questions coming in from the audience just now. So here, very important one. Should we be testing for FGFR alterations in all advanced UC patients? Do we test at baseline only or periodically? So my feeling is that you should test patients at the first diagnosis of metastatic disease, because it's going to take you sometimes many weeks to get that testing back, especially if you are sending it out to another lab like Foundation Medicine or somewhere else. And it's going to take time to get the tissue cut and then sent and then make sure there's sufficient quantity, and then they do the analysis and send it back to you. So do it ASAP in any metastatic patient. And then also in any patient who has a high-risk cystectomy after neoadjuvant chemotherapy. So if you have persistent muscle-invasive disease or greater, we know these patients are at high risk for relapse. Send that cystectomy tissue for next-generation sequencing. You'll also get it approved based on Medicare, because right now next-generation sequencing, at least by Foundation, has specific criteria, which is a metastatic patient or a relapse or progressor after chemotherapy. And so those are the two populations that will actually be reimbursed by insurance. And so in those two populations, I would strongly advocate for doing it as early as you can, because that information is extremely valuable and you want it right away. Now, doing it periodically, I am not aware of any sort of gain of function mutations in FGFR signaling that are actionable. So a patient who's FGFR wild type at presentation, and then after treatment and intervening therapy, that they suddenly have an activating FGFR2 or 3 mutation. So I don't know if there's much value in testing it periodically. Dr. O'Donnell, Dr. Grievous, have you seen cases where you develop a new FGFR alteration after intervening therapy?
Only the case we just did. That patient apparently was FGFR negative from whatever test was done initially, and then developed a mutation.
But in that case, we obviously we changed the case, right? So,
right.
Other than that, right? So that's been my experience. So I think the take-home message here is that we really only do it once, and do it early in the course of treatment. So now let's pivot. We've talked about really some complex cases in metastatic disease, first line, second line, third line, and beyond, molecularly targeted agents. Now let's focus on localized disease, both muscle-invasive bladder cancer as well as high-risk non-muscle invasive bladder cancer. So of course, let's begin with a case. We have a 45-year-old woman by the name of Ellen. She's presenting initially with hematuria. She gets a cystoscopy. She gets imaging done. She's got a sessile mass at the anterior bladder wall. She has a diagnosis of muscle-invasive bladder cancer, so clinical T2 disease, node negative, nothing else in terms of distant metastasis. And she's interested in bladder preservation options for the management of her muscle-invasive bladder cancer. So she's willing to consider everything, but she really is interested in something that could avoid having to undergo a cystectomy. So let's talk about how we approach discussions for these patients. Are there clinical trials of bladder preservation therapy for which she might qualify? I think this is an important opportunity for us to highlight, one of the most important organizations that all three of us work with very closely, the Bladder Cancer Advocacy Network, Beacon. It's a great patient-led foundation that supports both patient advocacy, policy, research, They are an important conduit by which patients get really, really valuable information about clinical trials. They have a wonderful clinical trials portal on their website, which is highlighted here for you on this particular slide. And it's really an important resource for patients, not only to connect with other patients who are battling this disease, but also to get really, really important information that might point them toward a particular study that may be a very good option for them. This particular patient is interested in bladder preservation therapy, but what is bladder preservation therapy? Kind of how we know it in both in the U.S. and outside of the United States is something called trimodality bladder preservation treatment, and it has several key components. One is the maximal transurethral resection of the bladder tumor. This is where a tumor is essentially surgically debulked through a transurethral resection. So it's kind of like a TUR, but a little bit more of an aggressive transurethral resection. And then it's followed by definitive therapy with chemotherapy and radiation treatment. So those are your three modalities. And ideally, the concurrent chemotherapy regimen is ideally radiosensitizing. And throughout the world, there's no real, optimal chemoradiation regimen. But I think, what we have seen most commonly used is weekly cisplatin-based treatment. So weekly cisplatin, 35 per meter given on a weekly basis. 5-FU mitomycin for patients who are not eligible for cisplatin, and then also twice weekly gemcitabine or even once weekly gemcitabine can also be given at very, very low doses because it is exquisitely radiosensitizing at very low doses. And all three of those are to varying degrees used as a standard throughout the world, albeit use of twice weekly gemcitabine is not that widely adopted outside of the United States, but it is to some degree in the UK. So this is kind of the framework for trimodality bladder preservation. And we know from randomized studies that chemoradiation is superior to radiation alone in the treatment of muscle-invasive bladder cancer to improve survival over radiation alone. But unfortunately, we are never going to see a randomized trial of chemoradiation or bladder preservation versus cystectomy. And so we have to have these balanced discussions with our patients and just highlight that both of them are standard options. Although I think all of us would agree that surgery is generally the most preferred option here in the United States. I'll talk about two specific studies that are really important. One is the SWOG 1806 study. This is a randomized phase 3 trial that is taking chemoradiotherapy as definitive management of localized muscle-invasive bladder cancer and asking the question, does immunotherapy improve outcomes versus just doing concurrent chemoradiation alone? It's 475 patients with clinical T2 to T4A disease, node negative, and patients are randomized to either chemoradiation alone versus chemoradiation plus atezolizumab. And the primary endpoint here is bladder intact disease-free survival, which is the most conservative way by which we measure how treatments can fail our patients. A similarly designed study is Keynote 992 with some important caveats and distinctions about how this study is designed, but ultimately is asking the question in 636 patients, very similar eligibility criteria, looking at trimodality therapy in a little bit more of a formal way in the sense that maximal TUR is absolutely required as part of the trial. But I would venture to guess that virtually all the patients in SWOG 1806 are also getting a maximal TUR as well. And here randomizing patients to chemoradiation alone versus chemoradiation plus pembrolizumab. Here again using the every 6 weeks dosing, maybe hopefully that might improve compliance and the use of treatment, and also using bladder intact event-free survival as the primary endpoint. And I think these are two very important studies that may ultimately prove outcomes that are superior to chemoradiation alone, and then also hopefully offer bladder preservation therapy to a higher proportion of our patients who are diagnosed with muscle-invasive bladder cancer. So let's move on to discussion. But let's say she says, okay, I've heard all you want to talk to me about, bladder preservation therapy, but I'm also willing to consider radical cystectomy. So Dr. Grivas, can you walk us through what are the current standards of care for perioperative treatment, neoadjuvant, adjuvant in bladder cancer? And then are there any other promising clinical trials testing novel agents in this particular setting, in the perioperative setting, whether it's in combination with cisplatin or maybe it's something else entirely? So can you walk us through some of that?
Absolutely. Thank you, Arjun. And just to make the note that this lady is very young, and a parenthesis here that it's a very important theme, emerging theme. We see many germline mutations in urothelial cancer, so I would definitely send this patient for genetic evaluation that can potentially have clinical trial implications for this patient, but also cascade testing for her broader family. So something to keep in mind for the audience to think about germline mutations in urothelial cancer, even more in upper tract, but also in bladder cancer. Having said that, the question here you posed, Arjun, is about neoadjuvant therapy. And there is level 1 evidence based on 2 large randomized phase 3 trials with cisplatin-based neoadjuvant chemotherapy. And the evidence was generated using the classic or older MVAC based on the SWOG 8710 trial. And the derivative of that, the MVAC minus adriamycin, the CMV regimen in the European trial. Both those trials were done about 15, 20 years ago. But together, plus a meta-analysis that also confirmed the overall survival benefit, all together generated a level 1 evidence standard of care of cisplatin-based neoadjuvant chemotherapy before radical cystectomy and lymph node dissection in muscle-invasive resectable bladder cancer. Now, the 2 regimens we use in clinical practice is either the dose-dense MVAC or accelerated MVAC with growth factor support given every 2 weeks for 4 cycles when you have muscle-invasive disease without lymph nodes, or we have the option of gemcitabine and cisplatin based on retrospective data sets and a single phase 2 prospective trial looking at gemcis. And gemcitabine cisplatin is given on a 21-day regimen. Growth factor is not required at the upfront, and usually we go, as I mentioned, for 4 cycles. It's important to point out that not all patients are fit for cisplatin-based neoadjuvant chemotherapy because of performance status 2, as you mentioned before, poor kidney function, severe heart failure, severe neuropathy, or some patients have significant hearing loss and they don't want to risk further high-frequency hearing loss with cisplatin. So those patients who cannot get cisplatin, right now they can go in a clinical trial, ideally, and there are plenty of them in cisplatin-ineligible patients. There are some phase 3 trials out there with pembrolizumab alone. There's another one with nivolumab plus Nectar-214 versus nivolumab versus no-neoadjuvant chemotherapy. And there is also a number of trials in cisplatin-eligible patients combining platinum-based chemotherapy specifically with checkpoint inhibitors. For example, we have gemcitabine cisplatin nivolumab versus gemcitabine cisplatin. You have gemcitabine cisplatin pembrolizumab versus gemcitabine cisplatin. And there is also the Niagara trial with gemcis durvalumab versus gemcis in that setting. So plenty of clinical trials trying to answer the questions. Now, in terms of immunotherapy alone in cisplatin unfit patients, we have some early promising data with immunotherapy as single agent. You see in that slide data from the PURO-1 study with pembrolizumab. Dr. Neki and colleagues showed data, and the Abacus trial from Dr. Pauls who had atezolizumab alone. Pathological complete response rate with single agent checkpoint inhibitor is between 30 and 40%, depending on the data set. And that's, as I mentioned before, support ongoing phase 3 trials. But I will make the point that immunotherapy right now is still experimental in the neoadjuvant or adjuvant setting. And I focus my discussion on neoadjuvant because we're going to discuss a little bit more about adjuvant in a second. But in patients who, as I mentioned, can't get cisplatin, that's my recommendation, gemcis or dose-dense MVAC with growth factor. If someone is not able to get cisplatin, either clinical trial or straight to radical cystectomy, I do not use carboplatin in the neoadjuvant or adjuvant setting in bladder cancer. And of course, as you mentioned before, adjuvant bladder preservation is an option. And now there is emerging data with immunotherapy. You see in that slide, either with Ipi-Nivo combination, there's phase 2 data. Still, as I mentioned, this is experimental and supporting phase 3 trials. And there is plenty of them, as you see in that slide. I mentioned already the Niagara trial, the Energize with Gemcis Nivo, the Keynote 905 with Pembro, Keynote 866 with Gemcis Pembro, and the nivolumab Nectar-214 trial. And as I mentioned, there's plenty of opportunity here for development and biomarker work. And I know both of you guys are doing a great work in that setting. So hopefully more to come. But I think the take-home point for the audience is if you have a trial, think about it, refer patients for trials in other centers. Do not use carboplatin neoadjuvantly in bladder cancer or adjuvantly. And in those who cannot get cisplatin, either trial or straight to cystectomy or bladder preservation.
So what about adjuvant trials? I think there was some ongoing studies that are really important. You know, we have the Checkmate 274 study, the Ambassador trial. These are both still ongoing and still collecting data. And in the case of the Ambassador study, it's still enrolling patients. But we also saw some data from a completed study, IMvigor010. And this was an important study that actually accrued very, very quickly and was one of the first adjuvant trials in bladder cancer involving immunotherapy that was presented at the ASCO annual meeting. And I think, I'm going to take a venture here and speak for my two colleagues here and say that the data from this particular trial was a real gut punch, right? When we saw the data for disease-free survival, and it's important, again, just to highlight the eligibility criteria for this trial, is that these are patients who had either neoadjuvant chemotherapy and persistence of muscle-invasive disease or greater at the time of cystectomy, or these are patients who underwent radical cystectomy alone and had high-risk features, meaning T3 or greater, and includes node-positive patients, and were not candidates for adjuvant cisplatin-based chemotherapy. So it took the highest risk population of patients. The evolution of this trial initially focused on PD-L1 positive only patients, and so really they were looking at that population, but then they realized, largely because there's activity in even PD-L1 negative patients, and also that it helped accrual so that you didn't restrict the population, eventually became an all-comer study. And so there's a little bit of an overrepresentation of positive patients. But even then, if you looked at the baseline characteristics for this study, about 50% of patients had node-positive disease. So you really had high-risk population of patients who went into this trial, and they were randomized either to atezolizumab or no treatment at all, just observation. And what you have here is disease-free survival, basically no significant difference, and whatever separation of the curve that was seen early on basically converged together at roughly the 18-month mark. Patients on this trial received basically about a year of treatment if they were randomized to treatment. And so whatever benefit they were getting basically washed away the moment you stop treatment. And so when we saw this data, is rather underwhelming, especially when the disease-free survival curves basically sit on top of each other toward the end. And even when you look at the outcomes based on PD-L1 status, what you see is that the PD-L1 overexpressing population, which is the IC23 group based on the SP142 assay, the difference in outcomes is actually even less pronounced, and the survival curves are basically, a DFS curves are basically on top of each other. What it does tell us, and it reminds us again, is that PD-L1 expression using SP142 and measured as IC expression is really prognostic, and you can clearly see that compared to the intent to treat population and also broken down by PD-L1 status. And we've kind of learned that both from the IMvigor210 trial, the IMvigor211 study, and then more recently the IMvigor130 trials. All of these trials together tell us that immune cell expression using the SP142 assay really does tell us a bit more about the prognosis of patients, and less so its use as a predictive biomarker. So let's pivot now and let's talk a little bit about patients with a non-muscle invasive bladder cancer, close out our wonderful case discussion tonight. So Evan, he's a former tobacco smoker. He's 78 years old. He's presenting with gross hematuria. He gets a CAT scan urogram and it shows mild thickening of the right anterior bladder wall. He gets a cystoscopy, a transurethral resection of a bladder tumor. He's got multifocal carcinoma in situ, no papillary disease whatsoever on multiple biopsies. And he ultimately receives a 6 of 6 installations of a full-strength induction course of BCG. At 3 months, he gets a cystoscopy, a urine cytology. He has a CR, right? So he represents about the 70% of patients who can achieve a CR to upfront BCG. And however, he gets a subsequent biopsy after maintenance therapy, and now he's got a persistent CIS. Okay, so he gets maintenance, and then he also gets persistent CIS. On biopsy, and also the urine cytology is also positive. On re-resection, no papillary disease, so he has nothing invasive, just diffuse CIS that is BCG unresponsive. So now, in this context, I think cystectomy is considered the standard of care. But of course, Evan, he says, listen, is there anything else that you can do for me, doc? Are there options that can help me avoid taking out my bladder? And so there's been major changes in this particular landscape. Immunotherapy is being now tested. And also there may be some other trials that may be critically important. So I'm going to discuss some of the data, emerging data for novel agents in this particular setting, especially for patients who have BCG unresponsive carcinoma in situ, but simply don't want to get a cystectomy. And I think I always begin conversations with my patients by telling them that cystectomy is the most curative option. Virtually 95% of patients or higher will be cured with a cystectomy in this setting. And so patients need to know that. And really, any therapy outside of that is likely to be inferior in terms of efficacy, but obviously major differences in terms of quality of life, because cystectomy itself is a highly morbid procedure, has a permanent impact on quality of life. And up to 4% of patients can actually die from the surgery, which is not really trivial, obviously. And so we know what we're up against in trying to avoid a cystectomy. So it was in this context that Keynote-57 was conducted. It was a multi-cohort study, but ultimately single arm in the sense that it tested pembrolizumab in two distinct patient populations. Cohort A were patients with BCG-unresponsive CIS with or without papillary disease. And cohort B were patients with only papillary disease. It was cohort A that was the subject of ultimately an FDA ODAC and ultimately what led to FDA approval. And in 96 efficacy evaluable patients, what we saw was about a 40% complete response rate at 3 months of pembrolizumab administered at 200 milligrams every 3 weeks. And then what we also saw was that longer follow-up, again, this is close to about 2 years of follow-up, is that about half of these patients who achieve a complete response will have complete responses that are lasting at least a year or longer. And in fact, at the last data cutoff, which was in September 2019, 17 patients are still in a CR. And some of these patients who I treated on this particular study are in a CR and have maintained that even off of therapy. And so I think that's one of the most critical pieces of information is that, and much like what we saw in advanced bladder cancer trials, is that the proportion of patients who benefit from immunotherapy may be relatively small, but that benefit is quite meaningful. And in some of these patients, we have perhaps avoided a cystectomy entirely. But it's important to recognize, again, cystectomy is highly curative in this population. So if they choose to use immunotherapy with pembrolizumab, we want to make sure that we're not harming our patients and the proportion who don't respond. And I think this slide highlights the access and assessment of subsequent therapy. And what we know is that roughly 36 patients out of the efficacy evaluable 96 ultimately underwent a cystectomy, including patients who have had never a complete response versus initial complete response and then subsequently developed recurrence, that these patients underwent a cystectomy. And the rate of pathologic upstaging in this population was only 3 out of the 36. And I've spoken to many of my urologic oncology colleagues in the field, and basically they've said that the proportion of patients who have upstaging to muscle invasive disease or greater at the time of cystectomy is easily 15% or more. And so what we see here is that that at least is not higher in this population. And so by treating with immunotherapy, we don't miss the opportunity for cure. And it's important that when this drug is used in the community setting, again, is that now it's FDA approved, is that we really follow the way that the trial was structured. So patients receive 3 months of treatment, and you got to take a look, cystoscopy, biopsy if necessary, and a urine cytology. And for patients who don't achieve a complete response, at that point, based on the trial design, patients should stop treatment and ultimately once again be counseled about cystectomy as a treatment option. There's some other exciting therapies that are currently in development, and some of which we may hear an announcement from the FDA. Natafarigine fiordenavec is a novel gene therapy product. So basically, it's an attenuated adenovirus that's encoded with the gene for interferon alpha 2b. It's encoded into the adenoviral gene, so it's instilled into the bladder, and ultimately bladder tumors uptake it and then take up the gene and then ultimately produce large quantities of interferon alpha 2b and generate a localized immune response based on the release of interferon. What's exciting about this particular agent is that it is administered once every 3 months, so it could be very attractive for patients. And so far, the data that we've seen presented is a roughly 25% complete response rate at 12 months, which is very similar to what we observed with pembrolizumab, and we may see an announcement from the FDA very soon. Vicinium is also a similarly designed agent. However, it's a single protein that consists of the EpCAM, a specific antibody fragment that's tied to a Pseudomonas toxin. Also, so it's a toxin-based delivery mechanism. So you have systemic immunotherapy with PD-1 blockade. You have an adenoviral gene product, which constitutively produces interferon alpha 2b, and then also a mode of delivery for the Pseudomonas toxin. And this is being tested in the VISTA trial. Ultimately, what I envision is that if all 3 of these agents are approved, or if it's only one, ultimately all of these will represent options for our patients who have BCG-unresponsive bladder cancer, and specifically for patients who wish to avoid a cystectomy. So thanks very much for joining us tonight. My colleagues, Dr. Grievous, as well as Dr. O'Donnell, thank you so much for joining us.
Such an exciting time in bladder cancer. I mean, if we think back to where we were 5 years ago, all we had was platinum, and now all these newly approved drugs and more on the way, more combinations. I think it's really great for our patients.
Absolutely.
I agree with Peter. I think it's a very, very exciting and rapidly evolving time. The paradigms are many, and hopefully we'll have more options for the patients. I see more combinations in the future, and I also hopefully more biomarkers select the right patient for the right treatment at the right time. And biomarkers are very hard to pursue, but we keep striving.
Yep. Thanks so much for joining us.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/MMX860. This activity is supported by educational grants from Bristol Myers Squibb, Janssen Biotech Incorporated, administered by Janssen Scientific Affairs LLC, and Merck & Company Incorporated. This activity has been jointly provided by Penn State College of Medicine and PVI, Peerview Institute for Medical Education.